Hello, good afternoon, everyone. Thank you all for being here. So I'm Angelina Quint. I'm a rising junior at UCLA majoring in public affairs and minoring in disability studies. And I'm a peer health educator intern with SHEP, which is Student Health Education and Promotion. And I'll be facilitating the Zoom event today on substance use and disability. So we can start off by having each panelist introduce yourselves and speak a little bit about your areas of work and expertise and how it relates to today's event topic.
Well, thank you for having me. My name is Kei Takahashi. I go by he, him pronouns. I'm a licensed psychologist and I serve as the assistant training director at CAPS, overseeing our social work intern and pre-doctoral practicum training programs. I'm a generalist by trade, not an expert in substance use disorders, but I completed my internship training at the VA Sepulveda Ambulatory Care Center, where I had a rotation within the chemical dependency unit, where they provide milieu treatment to veterans who have alcohol and other drug use disorders. And I also served on UCLA's Drug-Free Schools Commission, and I was supporting Bruins for Recovery when they were helping to establish the UCLA's Collegiate Recovery Program.
My name is Andy Luchter. I'm a professor of psychiatry at UCLA, and I'm delighted to be with everybody today. My work is primarily in the area of mood disorders and treatment-resistant depression. I do a lot of work helping patients who are suffering from depression, anxiety disorders, and a variety of kinds of psychiatric illnesses. These are, both the mood and anxiety disorders and substance use problems are major sources of disability that people really don't like to talk about a lot. So I'm here today and delighted to be part of the conversation. So thank you for having me.
Hi everyone, my name is Sage. I use she, her, hers, pronouns and they, them, theirs, and I am a MSW student at UCLA. I finished my MA in global health at UCSD. I'm the president for Bruins for Recovery. I helped start the Collegiate Recovery Program at UCSD, and I'm in touch with the UCLA founding members. And let's see here, I'm a CAE student, of course. So yeah, thank you.
Awesome. Thank you so much. It's so wonderful having each of you here with us today to shed some insight on this topic, given each of your individual expertise. So I guess before beginning with questions, it'll probably be helpful to the viewers if we can start by defining the terminology that we'll be using for today's discussion. So out of the following four terms, substance use, substance misuse, addiction, and substance abuse, which of these four, in your opinion, is the most appropriate to use, and why, and how would you define that term?
Well, I think those are, pretty different categories. So substance use refers to any use of a substance. Misuse falls into, I think, the category that oftentimes we think of through the definition that is numerical, right? I think it's 4+ drinks for female identified individuals and 5 drinks plus for male identified individuals, which is more categorical than sometimes helpful, but it just speaks to drinking more than the normative population. Use disorders is when we talk about the use then leading to functional problems. So either not being able to stop when wanting to, having to take in more of the substance in order to feel the same effects, having consequences within social environments, academic environments, legal consequences. And so that can lead to the category of abuse that is used.
Yeah, no, that's a really interesting question. I would agree with everything that Kay said. And I think, to take it beyond that to addiction, it really connotes a level of use and a need for use, so that an individual person has difficulty in coping and in functioning without using the substance. I want to pick up on one particular point that Kay introduced, and that is, what are the consequences of using a substance? So rather than quantifying it, because everybody has their own individual tolerance limits, It really, I think, in my mind, has to do with, is the pattern of use and the degree of use in which a person is engaging, is that a problem for them? Is it impairing their social relationships? Is it leading them to engage in dysfunctional behaviors? Is it making it a problem for them to sustain relationships or to work? So it's when the impact of the substance that somebody is using is really negative for them on a personal and interpersonal and professional level, that's when I start to get concerned about it. And I think that should be a signal to somebody that they need help.
In regards to terminology, I think it is subjective to the audience in which it's being used. I mean, I do know in the recovery community, whether it's smart recovery, 12-step, or other types, then substance abuse is usually not a term that is invited and as much liked by different people in recovery. People would rather use substance use if someone's talking about addiction as a topic or, as a category.
Thank you so much for that insight and for clarifying some of the language around this topic. So my first question is, what are some common myths or misconceptions that contribute to stigma associated with substance use and disabilities? And what are some overlaps between the two?
I think there are many misconceptions, so I'll just touch on maybe a few. I think the first that comes to mind is the idea of just a homogenous group. Like when we think about substance use disorders, sometimes I think there's a binary that's created, but it might be more helpful to recognize that each individual is going to have a very individual experience. Those that might be what we call pre-contemplative, those that don't really identify that there is a problem with the use patterns, will be very different from somebody who's been years into their recovery and has a greater sense of autonomy and ability to engage in activities that are more helpful to them. I think another misconception within that is that everybody has equal access to treatment. A lot of times treatments are very expensive and maybe not accessible to everybody. And there's certainly a disproportionate impact on people of underrepresented identities, which I think also translates to a place that we've made a fair amount of progress in our country, certainly within the broader concept of mental health. There's been a decrease of stigma, but I think in substance use disorders in particular, we're still falling behind that, where I think there still is a great sense of misconception that individuals struggling with use is falling into a moral failing concept, or that people are choosing to do this. So that they need like things like confrontations or interventions or hitting rock bottom. I think there's still a lot of that misconception still built into our society, which then translates to, I think, your original question of language, like that some people still fall into patterns of using language of dispositional qualities of the individual, like using the words like they're an abuser, rather than the behavioral description of they're having a use disorder. And through that further perpetuates this belief that there's a moral failing.
Kay's remarks are spot on in terms of how to think about these kinds of disorders. From the medical perspective, I think of these as sort of a classic gene by environment kind of constellation of disorders. That is, people have genetic susceptibilities to a predilection, if you will, to use substances, to sort of self-medicate, if you will, and that's something, that kind of vulnerability is persistent and with them. But the environment plays a big role too, in terms of, at times of great stress, at times of life turmoil, that an individual is more vulnerable and may be more likely to want to use, misuse, abuse substances at times like that. I really want to second what Kay said about this being a matter of choice. Now, obviously, somebody chooses to use or chooses not to use on some level. But this is, conceived of, I think, commonly as a moral failing or a sign of weakness, which is definitely not the case. These are illnesses. These are conditions that need treatment, but it's not the classic medical model of treatment. It's not, you take a pill and that cures a problem. It's also not necessarily you get psychotherapy or you go to a support group and that solves the problem. People do tend to get a little kind of formulaic in their approach, I think, to substance use disorders and say, oh, this worked for me and this is what you have to do, or this is the right approach. And there really is no right or wrong in these approaches to treatment. That is, it has to be, a very individualized approach to getting help. It's a blend of social support, group work, individual work, sometimes medication work, medical interventions as well, that really take more of a whole person approach to helping people who are grappling with these kinds of problems.
I want to say, in terms of adding on to everyone's comments, and it is definitely something that is much more complex than meets the eye. I've known that, for instance, with recovery, we've seen folks who go through harm reduction, which might not necessarily be abstinence. And so that's something folks think, say for instance, someone, uses drugs, but then they're able to drink. And so that's something that, is different for every person. And I think with the stigma, concealed stigma is really big in this area, just because it is something that is not as apparent as maybe a different type of disability. And so I know also there are co-occurring mental health disorders that occur within the communities. And sometimes, that is something that is needs to be addressed. And then, I also am a member of Bruin Guardian Scholars and former foster youth. And so I have seen folks who, might be as classified adult children of alcoholics or something of that sort. And there are definitely different paths to recovery. One size does not fit all.
Yeah, I wanted to jump in again in response to what Sage said, which I really support. These are complex situations. And when you've got a co-occurring mental health disorder, sometimes people need treatment for something like major depression or bipolar disorder or an anxiety problem, along with a sort of holistic approach to a substance disorder. One challenge that I sometimes face is, I'm working with somebody in recovery who's got a depression or who's bipolar. And, they're in a 12-step program. And some people in the 12-step program are telling them, no, you shouldn't be taking an antidepressant. You shouldn't be taking any medications when you're in recovery. And, from my perspective, and again, this is a matter of personal opinion, from my medical perspective, that's kind of a counterproductive approach because people, if they are suffering from depression, there are ways to help them and support them in recovering from depression or from an anxiety problem that are going to just enhance recovery if we can really help with the underlying mental health conditions as well. So sometimes that needs to be really called out and addressed specifically for individuals who are going through particular programs.
Yes. And definitely, I think with 12-step, there are some extremes. There is a group called the Pacific Group that doesn't believe in medication treatment for, substance use. And then if you have a co-occurring, but there are going to be opinions out there in every community.
All very great points, and thank you all for sharing. My next question is, what are some contributors to addiction among people like students, etc., with disabilities, and what do you believe are the most prevalent contributors? And are there any themes in the student population that stand out to you in specific regarding contributors to substance use?
I don't know that the contributors to these problems in people with disabilities are different, but they may manifest in different ways. That is, people want to fit in, people want to feel comfortable. To the extent that somebody has a disability, they may feel more isolated or more like they don't fit in. And, engaging in substance use or certain patterns of substance use may sort of be a way of fitting in. They may be a way of relieving stress, which may be somewhat greater for individuals who are coping with particular disabilities. Certainly if somebody has emotional problems, and that's a particular form of disability, then that use of substances, different substances, alcohol or other substances can be a way, as I was saying before, of self-medicating, of trying to take away discomfort, take away pain, making a social situation easier. So I think that those are at least some of the vulnerabilities that I think of offhand.
Yeah, in terms of contributors, it's different. I mean, I know that, as a former FOST youth, it's 7 times more likely, public health, degrees talk about this, of having a substance use disorder if you've been through the system. There are certain things that can, have those stressors, and like ACEs is such it's an outdated study. It's, from the 90s, and everyone talks about adverse childhood experiences. But I also know that it can, vary from different folks. And so that's why I just wanted to bring that up in regards to this question.
All the points I would just mostly second. There's so many different factors that could contribute. Neurological predispositions, genetic factors, within the comorbid conditions, I think that is where, like I said earlier, we have made such progress in destigmatizing mental health as a whole, but there are large, various communities where mental health is still very much stigmatized, and accessing care is so hard that, with an untreated condition, there is a need for relief as a human, right? And so there might be a greater predisposition to use substances to do that when the other avenues aren't available. And then I think it was already also mentioned the psychosocial environments. There's going to be certain populations, particularly at university settings, where there's greater vulnerabilities just because even just access, our nursing populations, our medical populations, that have more access to some of the medications might have a harder time. Those with pain management issues, plus the expectation of high pressure performance environments, such as our athletes, might be having greater vulnerabilities. And then, certain populations where there's a normalization of misuse makes it harder than to, follow a path of use that isn't going to lead to those functional problems or lead to any of the other predispositions being more acutely part of the picture. So
I think you raise a really important point there, Kay, and that was in terms of people with pain issues, people who are dealing with particular physical problems, because certainly in my own practice, I see individuals who are coping with chronic pain from a disability or from some medical illness. And sometimes, for example, alcohol would be the only thing that would help them find relief, or use of cannabis products. And some of those substances can play a role in managing pain. But again, it gets back to the issue of is it impairing function? So if at the same time you're trying to relieve pain, you're then impairing some other aspect of social or occupational function, or you're causing somebody to withdraw because they're impaired because of the substance issue, then you have to look at, okay, yes, this could play a role, but here the role it's playing is not a constructive role, and we need to kind of reassess that.
So, research suggests that there's been an increase in alcohol and other substance use within the disability population, in particular for those with mental health disabilities, as some of you mentioned in a previous question. In what ways do you think that the COVID-19 pandemic contributed to substance use within this population?
In regards to, I think it happened on both sides, both the 12-step SMART recovery and then the folks who might be doing their own type of recovery, whatever that is to them. Like, for instance, maybe folks were, working out instead of, going to meetings or whatever, but then like part of CrossFit community or something like that, and or yoga or such, or some type of other thing rather than the meetings, then they weren't able to use that outlet. And then, I've heard a lot about people who, got worse in regards to that. As a person in long-term recovery, I saw that a lot of people had struggles with technology, and that was like difficult for maybe older folks in the rooms of SMART or AA or NA, whatever type of 12-step group. And that was difficult because, as we know, internet access is a privilege, and it's technology. It is something that can hinder folks. And so maybe some folks were more isolated than usual, and that just like compiled. So yeah, speaking and seeing from experience what I saw in some folks, and also I guess in general, the increase within the disability population and mental health. This was a very difficult time for our country. Probably, the other panelists will second that, of course. And so I know it goes without saying, but at the same time, those activities and that socialization, like they say in recovery, connection is the opposite of addiction. And so you're losing that connection.
It's very interesting. I very much agree with what Sage has said about people getting out of their normal routine of connectedness and how that could be a problem for many individuals. I continued to treat individuals with depression throughout the pandemic, and to overly simplify things a little bit, you could say there were two groups of individuals with depression. One was a group that was kind of unaffected, if you would, by the social isolation, because these were individuals whose lives were already constricted by depression. And they would commonly say to me, now everybody else knows how I feel all the time, because I never feel like I can go out or I want to go out and see or be with anybody. So some people were actually somewhat comforted by the social isolation because they felt like everybody was in the same boat they'd been all along. The second group, though, that I encountered were individuals who were deeply affected by the social isolation because they had very few connections, and it was those few connections that kind of kept them on balance and kept them going and from getting too seriously depressed and self-destructive. And for those individuals, it was, a serious problem to lose the small vestiges of social connectedness they had. And indeed, some of those patients did start to get more into maladaptive patterns of substance use, things that were problematic for them, that led them to be even more depressed, more withdrawn. Things like alcohol can be a serious depressant, can make depression worse, in addition to causing kind of social dysfunction. So it definitely is something that I saw affecting a particularly vulnerable group of patients with whom I dealt.
I think those points are well taken. I'm always a little bit careful not to make correlation be causation. So, I do want to couch that a lot of these are hypotheses, right, at the moment, but it's hard to deny that there's some studies showing that even those who have never been using substances were then using substances for the first time with COVID, and that I think the opioid overdoses rates were going up significantly. So, it's undeniable that our world has experienced a great stressor as a result of COVID, through the things that Sage mentioned, like our usual coping mechanisms were taken away from us, or just the isolation that happened through this process. But we should also speak to the great amount of loss that happened during this time, people losing family members, and lost even opportunities, those that were unable to have their graduation ceremonies or life events that were taken away. So while I think there is both sides of the coin, the move to the internet did allow some greater access to being able to engage in recovery communities that were online, where previously it was maybe harder to access a meeting. As Sage noted, not everybody had access to the internet, or some things were substantially harder. So I think that with all the things going on, it's hard to pinpoint one thing, right? Like the loss of jobs and economic opportunities, being able to pay your rent, and all those stressors probably combined in some format to see some of the spikes that we're noticing.
Thank you for all of your insight on that question. Given your knowledge, experience, and expertise, how do we balance the need for prescription medication and pain relievers with the dependence and addiction that may come with that?
Yeah, I mean, this is something that in medicine we deal with all the time, in terms of we have medications that can be of tremendous benefit to individuals, but at the same time, they do carry some liability for causing dependency. I think that first, we need to recognize that most individuals, most people who come into treatment for various problems, it's not that they're coming into treatment because they're seeking substances, that they want to get dependent on substances. There is a group of individuals who are perhaps more susceptible to this, as we were talking about before, but most people will choose to use a medication for the problem that it's given, and then want to discontinue use as the problem goes away. So I think that's one important thing to keep in mind. The second is that we really don't want to be paternalistic about this. We don't want to say, no, I'm not going to give this to you, even though you would benefit from it, because I don't want you to get dependent on it. I think, that is a counterproductive approach to people with pain disorders and anxiety problems. You need to have a partnership with the patient. There needs to be a collaborative relationship where, you have open discussions about these kinds of issues. That is, here is a tranquilizer, a medication like a Xanax or a Valium. And I think this could help you with your anxiety. You do need to be aware that if you use this too much, too regularly, it may start to lose some of its potency in relieving your anxiety, and you may have to take more and more of it to get the same effect, and that eventually it may be hard for you to stop using it because you'll get so used to using it. That's a discussion. That's a conversation to be had. And you can really establish very good partnerships with people who need medications that will help avoid any of the pitfalls of overuse or misuse. Of course, there is a responsibility that physicians have to monitor use. That is, if you prescribe an opiate for somebody, you don't want to just give an open-ended prescription to say, oh yeah, you have this for 6 months and call me back in 6 months, let's see how you're doing. There has to be some monitoring, some interaction, some discussion of the role that it's playing in the patient's life. But I think if there is good collaboration, that this can be a positive relationship in which physicians can help, patients can be partners in that decision-making process, and we can avoid some of the downsides of use.
Yeah, I had a feeling that was a good person to start with. I love all the things Andy said, like absolutely, right? Like just thinking about the individuality of the human being you're working with, right? Like I think that as you were mentioning, I realized that is another misconception we didn't address, is this idea sometimes people have of an individual with a use disorder cannot make their own decisions or needs somebody else outside of them, which is incredibly infantilizing and problematic. I love the idea of, with any treatment, starting with a great amount of psychoeducation so that you empower the person that you're working with to make those decisions. And from that, discussion, it might be that you discover that the values of recovery are worth pursuing alternative paths to whatever conditions being treated. For pain management, looking for alternative ways to engage in physical therapy or mindful meditation, cognitive behavioral therapy, holistic medicines, alternative medicines, might be the place to go first. And then if then from there's a desire to engage in some of the pain medications, well, again, starting to explore, are there pain medications other than opioid medications that could address some of these pain issues? Or if an opioid medication has to be chosen, can it be one that maybe has the least amount of euphoric effects attached to it? And seeing with the person you're working with, would you like others involved in your care, involving family members or friends, so that they can choose who they would like support from? And even creating schedules with the person you're working with. Maybe we should meet more frequently, so that there's a lesser amount of medication that the individual's holding, and there could be greater points of contact. And the other point that Andy mentioned, so important, is to have collaborative care, right? To have your pain management physician speak to your PCP, speak to your, if you're in addiction medicine, to have those individuals all collaborate and speak together too, so that it's not this idea of I have the idea that's best for you and let me implement it. I believe that all these are actually in line with SAMHSA's recommendations. They put out I think close to a 90-page document on how to support individuals with pain management who are having substance use disorders. And it all kind of focuses around really empowering the person in front of you and working collaboratively with them.
I would agree with everything. I really don't have a lot to add, except for, I guess, Suboxone has been really helpful for a lot of individuals that had a former maybe heroin addiction.
Yeah.
So that would be something I would want to add to the conversation, which, some folks are unsure about adding.
Yeah, I think that's a great point, Sage. I'm really glad you brought that up. Suboxone can be of enormous help. There are a limited number of people who are able to prescribe that. You have to have a special permit in order to do that. But seeking out somebody who's qualified to work in that area can be a great help to somebody who's been struggling with opiate problems.
How does UCLA, in your opinion, support students with substance use and or are in recovery, and what resources are available to them?
Hi. Okay. So, I do know that my friends, my friend Rachel Scott, a couple of years ago, was able to start the UCLA Collegiate Recovery Program because she got a huge outside donation, over 10 grand. And then the university started to involve CAPS and all that good stuff. It wasn't until that they got that outside donation, and that's stigma for you. So the Collegiate Recovery Program is for anyone, whether they're in recovery, thinking about starting it, and it also could include folks that maybe are in a different type of recovery, like food or gambling. But for the most part, there are quite a few folks that are looking for abstinence, but also individuals who aren't really sure. We get folks like that have court cards. That's always fun. But I do know that like in all the UCs, we've had struggles with UCPD, and that we lack support there. Or if students get ticketed for something, you know, rather than maybe like offering the collegiate recovery program information, they get like cited or something, which I would really like to see in the future, like student health work more in a collaboration rather than maybe a penalty for individuals that are suffering. And so that's something I just would like to bring up. But for right now, we are housed in the Bruin Resource Center. We're technically institutionalized somewhat. Our next program director is going to be working simultaneously with the Underground Scholars Program, mostly just because UC Regents gave a bunch of money to all of the Underground Scholars Program, which is individuals that have been formerly incarcerated or their families were system impacted. There is some overlap in that population with ours, but you know, I just wanted to add that point. So yeah, it might be a really long time until we have our own program director dedicated like full time to us. But as of right now, we do have a space where we can have our meetings, which is really great, in the Bruin Resource Center, which Paulo has been like crucial in helping us get, the director. And we're opening meetings. We have a BIPOC meeting now. We have an LGBT-centered meeting. And then we have non-recovery, and then we have one 12-step meeting a week. I
want to just reiterate just all the things that Sage said. The Bruins for Recovery is the heart and soul of our recovery at UCLA's campus, and really should be noted for how much they've accomplished over the years. You know, recovery communities exist on multiple college campuses, but not every campus has been able to create what Bruins for Recovery has. You know, having advocated for the university to support them through a dedicated staff through the Collegiate Recovery Program is huge. To have meetings available so frequently and to have space allocated to recovery is huge. So I can't speak highly enough of all their efforts. But just a reminder that, you know, at CAPS, we have generalists who are trained to be able to support students at various levels of, you know, identifying whether they have a use disorder, or if they're struggling, or if they're already in the process of recovery or 30 years into recovery and really needing more focus on the comorbid conditions and really wanting support there. And we also, you know, do a really nice job of helping to support 2 higher levels of care, which we don't have available. Like we don't have a detoxification program or milieu treatments or, you know, residential care. But we certainly have those partners that we've created over the years in the community, so we can always help in connecting for those services. And I think it's also a good point that Sage mentions, like there's still in our country and certainly still on our campus an overcriminalization of substance use problems. And so, you know, we do need to work even better at trying to find ways to support individuals when they're in these you know, places of struggling with their functioning, to be able to engage in treatment and get connected. The police department has been working with, I believe it's through a direct connection with Res Life, to create some diversion options so that if there are police arrests that they, for first time infractions, they do have the option to attend a lecture and write a reflective paper instead of having time through the judicial system. But again, there's still a lot of room for that to be improved too.
In my experience, CAPS does a terrific job of helping students decide where to go. I mean, one of the challenges on our campus is not that there are too few treatment options, but there are way more than anybody can possibly sort through. And figuring out how to access them can be a real challenge. So I encourage students to talk with the folks at CAPS, talk with people in the Bruin Resource Center to learn about the different options. You know, because the medical route of treatment, you know, we do have programs in the Department of Psychiatry, and as Kay was mentioning, there are programs in psychology as well. But I think that, you know, getting a broad overview of the resources can be very helpful. I did want to touch on the legal aspect of things for a moment, because I do think that is a challenge that many students face, that they get cited for an infraction of various different kinds, and they are introduced to the legal system. And there are ways to try to get out of that. There are diversion programs. One thing that I always encourage students to do is take advantage of UCLA Student Legal Services, which is a terrific program that can advise students on their rights and opportunities, and can sometimes help work toward a diversion alternative and take something out of the criminal justice system. So I think that it's important for students to really learn their rights, and the Student Legal Services, either through their website or in terms of in-person service, can be very helpful in that regard.
And then what recommendations would you make to medical, educational, and other institutions to support disabled individuals with substance use and/or who are in recovery?
I think first we do need to keep advocating at a national level to destigmatize substance use. There's still a discrepancy between those who have disabilities based on other mental health conditions and the access to supports that they can get versus those with a use disorder. And so I think that needs to change. At the institutional level, I think kind of following the model of UCLA is a really great one. Dedicating staff that are there for students in recovery, allocating finances and resources to those students, creating housing options for those in recovery, again, to create a safe environment for those that are wanting to pursue sober living or different lifestyle choices. Also for programming that focuses so much on substance or at least alcohol use in events, to create alternative sober programming so that those that want to can engage in that. Those are kind of the ones that come to mind.
Yeah, it's a really good question, Angelina, and I like Kay's answer a lot. I want to come at it from a slightly different perspective. That is, as an educator, as somebody who is teaching medical students and residents as to how to interact with people who are struggling with a substance problem. And what I try to encourage people to think always in approaching such individuals is the basic philosophy should be everybody's doing the best they can. Nobody wants to be dependent on substances. Nobody wants to abuse drugs or alcohol. This is a way that people are trying to cope. And that we have to come at things from the standpoint of, how can I help this person to recover? How can I help them to do better, given the difficulty in their life? Whether they are, somebody who's dealing with a lot of psychosocial stress because of a divorce or loss of job, or financial problems, or somebody's former foster youth. Whatever issues they're bringing to the table, they're just trying to deal with the things that are going on in their lives. So we need to listen to them, and we need to provide the kind of support that they need. A lot of the things that Kay was talking about are some of the things that are available, but in order to get people plugged in with the help that they need, we first have to listen and be compassionate, and to really help direct people and support them in getting the help they need.
I agree with, of course, everything has been great that's been said. One of the last points, I guess, was the Association for Recovery in Higher Education, which the director, Tim, has done a great job. And I just recently spoke at their conference, which was really cool, but it was online. So yeah, COVID safe, but I would definitely say there is models out there for colleges. And I'm hoping that collegiate recovery programs in the next 10 years can be on campus, just because of you know, Kai brought it up already, but you know, the struggles that individuals who are already in recovery, which is something I think that people forget about, like, you know, long-term folks exist on college campuses. Some of us, like myself, I entered recovery at age 19. And so it's like, you know, and it's a difficult environment to maintain that recovery, or the individuals who are questioning and stuff like that. And so it is really needed. And I'm really hoping, like, funding wise, that schools can be institutionalized like UCLA, because it is a privilege. I had a fellowship offered to me for an MPH program, all paid for at UCSD, and I turned it down because the environment was not as what I wanted to be a person in recovery, and I was tired of it. And so I went to UCLA, and luckily the funding came through and everything was fine. But, you know, I left a fully funded fellowship because of that school's climate. And, you know, I think a lot of folks kind of overlook that. But of course, like medically, there are so many advancements that we can look at with medication and everything we've learned from the opioid epidemic. So, of course, lots to share.
And then my last question for you all is there anything that we didn't cover that you would like students, staff, and faculty to know? And feel free to add anything else that you might want the viewers to know as well.
Yeah, there are probably about another 6 hours of things we didn't cover. And, you know, we could talk about these topics all day, but I think, you know, the take-home message from my standpoint is that, you know, there is lots of help available. That this campus has lots of resources and lots of people who want to help support people with disabilities, people who are in recovery. So reach out and get the help that you need. You know, the major barrier for many people is the shame and stigma of just saying, I've got a problem, I need help. If you get past that, recovery is very possible.
Like Andrew said, there's a lot to cover and talk about. And this is just, you know, different areas that maybe are, you know, in the media, in the news, and things that are really relevant in that regard. So I'm happy we covered these questions. And Angelina, you did a great job of that. And so, yeah, in the end, I guess if I'm going to add anything, it's just that, you know, it is a population that has many marginalized individuals inside of it, and we have intersectionality. And, you know, by supporting this program, you're supporting students that also belong to different resource centers on campus, or are maybe the most disadvantaged of students who have been through some really difficult life situations. And so, you know, I also want to say to any students that are maybe, you know, hesitant, of course, like, you know, the Collegiate Recovery Program, CAPS, and all these different resources are like a warm welcome, no matter if you're questioning and unsure, you know. So just wanted to say that.
Yeah, I just want to echo my appreciation that attention is being given to this topic, and thank you for hosting this. And also, yeah, I want to just reiterate, no human being is, you know, an island. Like, that we are best as a community when we're all interconnected and we're supporting each other and we're recognizing individual differences. And that applies to so many different aspects of life, but certainly to supporting recovery. Like, community is amazing. And when we support people through community, that is when we thrive. So I'm grateful for Bruins for Recovery and all the other resources on campus.
Thank you all so much. That's all the questions that I have for you all. But I just wanted to echo my appreciation for all of you for being here and for all of the work that you are continuing to do. It's really appreciated. So thank you.